Good afternoon, everyone. I extend a warm welcome to each one of you as we kick off the exciting journey to the Nclex series, and this is part 2. It brings me great pleasure to have you all on board. The primary objective of this class is to equip you with the essential skills and knowledge required to tackle the new generation Nclex that you will encounter once you take the exam. Throughout this webinar, we will delve very carefully into selected topics that are considered to be high yield in the Nclex. My role here will involve presenting a comprehensive lecture on the chosen topic, followed by a practical case study that you will engage with and respond to. It is important to note that the new generation of the Nclex examination features 3 case studies, each having 6 questions, totaling up to 18 questions in total. Allow me to introduce myself. I'm Dr. Tom Madayag, a faculty member in the BSN program here at Broward College. My journey with Nclex Review dates back to 1996. It's been a long time ago. And in 2002, I authored an Nclex review book, which is a testament to the dedication to helping aspiring nurses like yourselves. My interest in the Nclex started actually at Broward College when I was asked to teach a remedial course for those who failed the Nclex examination for the first time. So over the years, I've had the privilege of conducting Nclex seminars in diverse locations, including Jamaica, the UK, India, the United Kingdom, the Philippines, China, and Canada. So drawing from this extensive experience, I'm committed to providing you with the guidance and knowledge that is going to be necessary for your success in the Nclex. So I look forward to our shared learning experience. And so we're going to have our topic for today, which is going to be on heart failure. So for those of you who missed the class yesterday, there is a recording that is available to you. I had put that in the Google document so that you can access it as well. This is also recorded so that you can always come back to it should you desire to do so. All right, so let's go ahead and get started and talk about heart failure. So when we have heart failure, this is a syndrome. So it's not a disease in itself, but rather a collection of signs and symptoms that is characterized by fluid overload and inadequate tissue perfusion. So imagine that you see this patient. You're going to see a patient complaining of activity intolerance. That's the one thing that patients with heart failure are going to manifest. The other things might be manifestations of fluid overload, such as jugular neck vein distension, peripheral edema, complaints of shortness of breath, as well as activity intolerance, as I have mentioned. So heart failure is defined as a clinical syndrome. And as I said, it is a collection of symptoms which are going to be characterized by fluid overload or inadequate tissue perfusion. So according to the 2013 guidelines on heart failure, we should no longer refer to this condition as congestive heart failure, because not all situations of heart failure are characterized by congestion. Hence, if you still use the term congestive heart failure, please go ahead and remove that from your dictionary, because the definition has now changed to heart failure, simply because not all heart failure cases are characterized by congestion. So before we go to a discussion on heart failure itself, we're going to have a basic understanding of cardiac function to grasp how heart failure affects the heart and the body. So the heart failure limits the ability of the heart to pump enough blood to satisfy metabolic demands. And so it is important to talk about cardiac output as well as stroke volume and in relationship to heart failure. So let's talk about cardiac output. So what is cardiac output? You're now going to have a blank screen because I'm going to be writing some things. And so when we talk about cardiac output, it actually is a sum of stroke volume and heart rate. So if you have cardiac output over here, it is going to be stroke volume times heart rate. So it is influenced by two factors. Normally, we have a normal cardiac output of 4 to 8 liters per minute. Oops. And this is going to be influenced by the product of the heart rate and the stroke volume, as I had said. So let's talk now about stroke volume. What is stroke volume? Well, stroke volume is the volume of blood that is pumped from the heart with each ventricular contraction. So if I had a ventricle that's filled with blood, the amount of blood that's ejected in a minute, I mean, in one heartbeat, I should say, is what is known as the stroke volume. And normally, a normal stroke volume is anywhere between 50 to 100 mLs. Clear enough? All right. So this volume, however, is influenced by several things. What are the variables that influences the stroke volume? Well, the stroke volume is influenced by what is known as preload, an afterload, and also the strength of cardiac contraction or contractility. So let's go back to this idea of preload. When we say preload, what are we talking about? Well, it is almost likened to you are moving from one house to another. So I have an analogy, and you have a small home, and you're now moving to a bigger home. And of course, your big home will have a big door as well. And you will also have a side door because now you're rich. Okay. All right. So you want to move your items to the new home. So you rent a U-Haul truck and you fill your U-Haul truck with everything that you own. All right. And now, of course, you're going to go to your new home. And there are two doors, as I said. This is door A and this is door B. Okay. Which one would be easier for you to unload all your stuff? Would it be door A or door B? Could you please answer in the chat box? Which door would you use so that it will be more, or it will be easier for you to move the things into the new house? Door A. Okay, Perlier said door A. A lot of you said that. Okay, wonderful. So this is the analogy, and now I'm going to tell you the analogy to the heart. Now, when we have our heart right over here, and anything that we put in the heart, particularly the ventricles, is what is known as the preload. All right. So which means to say that the higher the preload or the more preload that you put in, the more stuff you're going to deliver to your new home. Correct? So preload then is going to be likened to the amount of blood that comes from the venous circulation So from your vena cava, for example, that goes into the right atrium and eventually to the right ventricle, the left atrium and left ventricle, that is the preload. All right. So if you have an increase in preload, what would happen to your blood pressure? If you have an increase in preload, what would happen to your blood pressure? Will it increase or will it decrease? Yes. The more you put into the heart, the more cardiac output or the more stroke volume there's going to be. And therefore, an increase in preload will increase cardiac output. It will also increase blood pressure. Okay, so that's the preload. Now, the heart has to empty its contents. And so the heart is going to empty its contents, particularly on the left side, and it is going to be influenced by the narrowness or the size of the arterial walls. So let's say that you're going to have a blood vessel that is like this, and that's blood vessel A, and blood vessel V is going to be this size. Which one would it be easier for the heart to unload its content? Would it be letter A and letter B? Letter B, very good. So the resistance then against the force of blood coming out over here is what is known as the afterload. Okay? So when you are vasoconstricted, you're going to have an increase in afterload. If you're vasodilated, you're going to have a decrease in afterload. So again, the stroke volume is going to be influenced not only by the preload, the amount of blood in the ventricle before contraction, but it also is going to be influenced by the afterload, which is the resistance or the impedance that must be overcome for blood to be pumped from the ventricles. All right? So we need to understand these concepts right over here in order to be able to appreciate what heart failure is going to do. All right? So the other term that I wanted to talk about is going to be your ejection fraction. But I just wanted to summarize what preload is. Again, it's the amount of ventricular stretch at the end of diastole. It's also known as the left ventricular end diastolic pressure, but we call it more preload. And of course, afterload is systemic vascular resistance. It is the force against which the ventricles have to overcome to eject blood. And then, of course, obviously, it is going to be influenced by ejection fraction, contractility as well. All right. So the next term that we're going to define is ejection fraction. So what is ejection fraction? This is a measurement which is expressed as a percentage of how much blood the ventricle pumps out with each contraction. So what does that mean? Again, if you fill these ventricles, for example, with blood, and let's say now that this ventricle is now full of 110 cc's of blood, the amount of blood that is ejected with each contraction is what is known as ejection fraction. Now, a lot of people think that when you fill the ventricles with 110 cc's of blood, that everything is going to go out once the heart contracts. And that is not so. Some of it is going to remain in the ventricles. Okay? So let's say now that 55 cc's comes out. What would be the ejection fraction? The ejection fraction is 50%, isn't it? So it's the amount of blood that is going to be ejected from the ventricles as a result of cardiac contraction. So normally, our ejection fraction is approximately 55 to 70%. So normal ejection fraction is anywhere from 55 to 70%. And if you have an ejection fraction that is going to be 40% or less, so it's going to be 40% or less, this is going to be diagnostic of heart failure. So let me repeat that again. If the ejection fraction is going to be less than 40% or less, this confirms the diagnosis of heart failure. Okay? So how do we measure ejection fraction? What are the tests that are used to measure ejection fraction? Well, the number one test that we use at the bedside is echocardiography. But we could also measure it by using cardiac catheterization, by measuring the pressures as well as the volumes that are going to be ejected. You could also do it by nuclear medicine or even with CT or computerized tomography. But the most common way for us to evaluate or to measure ejection fraction is echocardiography. Okay, so important things that we have learned so far, because there are several values that we had talked about. Do you remember what normal cardiac output was? Hello? Did you remember what normal cardiac output was? Yes, very good. 4 to 8 liters per minute. Very good. And of course, what is the normal stroke volume? Because you remember, we were defining this thing. Cardiac output is the sum of the stroke volume and the heart rate, 50 to 100 mLs. And what is the normal ejection fraction? Normal ejection fraction? All right. So we said that the normal ejection fraction, if you remember this definition right here, is that we are going to have 55 to 70%. And what confirms the diagnosis of heart failure? What confirms the diagnosis of heart failure? Okay, an ejection fraction of less than 40%. Very good. Okay, so now we're ready to talk about heart failure. Now, when we talk about heart failure, we're actually talking about two things that might cause heart failure. So in essence, there are two kinds or two types of heart failure, and that's exactly what we're going to be talking about next. So if you have heart failure, it could be caused by a systolic dysfunction, or it could be caused by diastolic dysfunction. And therefore, we refer to this as a systolic heart failure or a diastolic heart failure. So let's take a look at systolic heart failure. The problem with systolic heart failure is a problem of contraction. So what do I mean by that? So maybe the heart fills with blood, but because the heart is weak and the contraction is very weak, what's going to happen is you will have a decrease in ejection fraction. So it's similar to, I have a balloon over here, and I hope that you can see my balloon. And I'm going to blow this balloon similar to the ventricles being full. Now, what if I just push this balloon very lightly? Will all the air come out? Will the air come out efficiently? No. So this is going to be similar to a systolic dysfunction resulting in heart failure. All right. So why is it that the contraction is going to be weak? What causes the contraction to be weak that would lead to heart failure? Well, let's say an example of that would be myocardial infarction. When you kill some of these walls of the ventricles, for example, then you're only going to be left with those that survive. And therefore, you have lesser muscle mass to exert cardiac contraction. And that is exactly the problem with systolic dysfunction. Okay? All right. So the other type of heart failure is what is described as a diastolic heart failure. And in diastolic heart failure, it's a problem of filling, or in the diastolic phase. So the problem is in filling. All right. So let's say that you have two containers of exactly the same size, but one container has very thick walls. So the wall of this container in B has thick walls. Now, if I fill both of these containers, which one will accommodate more? Is it letter A or letter B? Letter A will accommodate more. Very good. So, ladies and gentlemen, this is exactly what happens when we have a diastolic heart failure. And what happens in diastolic heart failure is because of some architectural changes within the heart as a result of heart disease, what could happen is that the ventricles can thicken. And this thickening is what is described as concentric hypertrophy. The hypertrophy, or the increase in the muscle mass, is occurring in the center, and therefore it will decrease blood volume. Whereas over here, the hypertrophy, if you merely enlarge the size of the heart, this is what's called eccentric hypertrophy. All right. So going back to this diastolic filling then, in a diastolic heart failure, the problem is not with the contraction, but rather with the filling, because now the heart can accommodate only a lesser amount of blood. The ejection fraction will be normal because you still have a lot of muscles to eject it. And it might even be high because you have a lot of muscles. Whereas in systolic heart failure, you're going to have a decrease in your ejection fraction. Okay? So let's go now to summarize these things that I've talked about as far as heart failure is concerned. When the heart becomes enlarged, and the hypertrophy or the enlargement results in eccentric hypertrophy, meaning to say that the size of the heart will enlarge. This results in a decrease in ejection fraction because you now have an overstretched ventricle. Okay, so let's say that you have a rubber band and you keep on stretching the rubber band. Will the rubber band become stronger or will it become weaker? It will become weaker, isn't it? And that is exactly why we develop a systolic kind of heart failure. All right, because of the fact that the muscles have now been overstretched and some of them are dead, and therefore the contractile force becomes weak. Over here on the left side, in the hypertrophic cardiomyopathy, wherein the hypertrophy occurs inside, this is what's called concentric hypertrophy. Notice that the muscles are now very thick, and it results, therefore, in lesser volumes of blood. Okay? So, what do we have over here in this letter B? What happens to ejection fraction? What happens to ejection fraction in letter B? Okay, it will be decreased. Okay. And how about in letter A? What happens to the ejection fraction? What happens to the ejection fraction in letter A, right over here? You have a lot of muscles. Yes, it will be normal or it could be elevated. Very good. Okay. So the definition or the categories of heart failure are going to be classified based on whether or not the ejection fraction is normal or abnormal. So we can have heart failure with reduced ejection fraction. That means to say that the ejection fraction is less than 40%, or a heart failure wherein there is a preserved ejection fraction. So that's HFpEF, wherein the ejection fraction is greater than 50%. Now, the other thing is that we could classify heart failure by its onset. Is it acute? If it is acute, that means to say that this is something that occurs immediately, such as what happens as a complication of an acute MI, severe hypertension, acute myocarditis, and pulmonary edema. Or it could be chronic, which means to say that the patient can have this symptomatology over a long period of time. And lastly, it could be on the left side of the heart or on the right side of the heart. Okay, so in order to make it clearer, let's talk about systolic heart failure and diastolic heart failure then. The summary is that in systolic heart failure, the problem is contractility or the pumping ability of the heart. There is going to be decreased contractility, and therefore there's going to be a decrease in the ejection fraction from the ventricles. And of course, as a result of that, preload increases. So I want you to remember that these events occurs in systolic heart failure. Now, in diastolic heart failure, we said that the problem is in filling, the contractility is not affected, and usually it may be caused by the muscles being stiff, but anyway, the important thing is that the ejection fraction is going to be normal, and the preload could be normal or decreased. All right. Are there any questions as far as systolic versus diastolic heart failure to begin with? I'm going to pause to see if you have any questions as far as systolic or diastolic heart failure. Okay, let's go now to the fact that heart failure could occur in either the left side or the right side of the heart. And so let's take a look at the difference and what happens when it is on the right side or on the left side of the heart. So again, I believe in analogy. And so you are going to Sunrise Boulevard, and there is an accident right over here. Okay. So there are 2 points. A is before the accident, B is after the accident. So the traffic is going this way. Where would congestion happen if there was an accident in this area? Would it be point A or point B? Where would congestion occur if in Sunrise Boulevard we have an accident right over on this lane? Would it be in point A or point B? Okay, so congestion will occur right over here. All right. Now, the reason why I'm saying that is because I want to compare that to the heart. And so allow me to diagram the heart schematically. And so if this were the right atrium and the right ventricle, and this is connected to the pulmonary artery and the lungs, and now pulmonary vein into the left atrium and the left ventricle. All right. So let's say that the one that is not efficiently pumping is the left ventricle, right here. Where would traffic back up? Where would traffic back up? You remember blood is moving this way, right? All right. So it will eventually back up into the pulmonary veins and therefore the lungs. So in left-sided heart failure, the majority of your symptoms are going to be pulmonary in origin. There's going to be pulmonary congestion, and there's going to be symptoms associated with impairment of gas exchange. All right. So left-sided heart failure will always result in respiratory problems or oxygenation problems. So the patient might become short of breath, the patient will have crackles, the patient might have tachypnea, and they might have desaturation or a decrease in their O2 saturation. So all those are going to be problems that are going to be associated with left-sided heart failure. So let's now go to the right side of the heart. And so again, I'm going to draw right over here, the right atrium, the right ventricle, the lungs, the left atrium, and the left ventricle. And then, of course, the one that is going to connect the right atrium is the vena cava. All right. So let's say that what fails is going to be your right side. So let's say that this right side is the one that failed. Where would the congestion occur? Where would congestion occur? All right. So the vena cava and then the venous side, right? And so the vena cava actually is connected to your liver, to your circulation through your GI system, and the periphery. So all parts of the body. Periphery. So whenever you have a dysfunction of the right side, therefore, what's going to happen is you're going to have jugular neck vein distension. You're going to have hepatomegaly, and because the liver is sort of hepatomegaly connected to the spleen, you can also have splenomegaly. You can have ascites as a result of it, and then you're going to have peripheral edema. Okay, so in right-sided heart failure, the congestion is going to be in the peripheral tissues and the viscera, and it is going to be characterized by venous congestion. All right? Okay, so heart failure could be compensated or uncompensated. And when we say compensated, that means to say that rescue mechanisms from the body is going to act up as a result of a decrease in cardiac output. So when there's a decrease in cardiac output, what does the body do? Well, they compensate by stimulating the stress response. The sympathetic nervous system is going to be activated, and it's going to release natriuretic peptides. And these are peptides that are released if any of the walls of the atria or the ventricles are overstretched. And they release these particular peptides in order to increase cardiac output. They could also activate the renin-angiotensin-aldosterone system. And if we remember about the renin-angiotensin-aldosterone system, what this eventually does is that it releases angiotensin 2, and angiotensin 2 is a potent vasoconstrictor, and therefore it will increase blood pressure. Angiotensin 2 also activates another hormone, and that is aldosterone. And aldosterone is going to increase sodium reabsorption and eliminate potassium. And of course, the Frank-Starling mechanism means to say that the body or the heart now tries to stretch itself as much as possible so that it can contract more forcefully, but the Frank-Starling mechanism will die off after it's been used for quite some time. Similar to this rubber band, if you keep on stretching it, it's going to lose its contractile force. So when we say that the heart failure is compensated, that means to say that the cardiac output is going to be normalized as a result of all these compensatory mechanisms. The symptoms, therefore, will be minimal, or there are no symptoms at all. However, in uncompensated heart failure, the symptoms are present. It could either be in the form of lung congestion, or it could be peripheral congestion, which would include your peripheral edema, as well as your hepatomegaly and ascites. So let's now go to a first question that I have. And now I have prepared a poll. So all right, do you see question number 1? Do you see the question? Yes? Okay, which patient teaching statement is not accurate on left ventricular systolic dysfunction? Please answer. Very good. Letter D is the correct response. We're looking for a statement that is not accurate regarding left ventricular systolic dysfunction. Okay, so signs include cough, difficulty of breathing, and weight gain. That would be true for left ventricular systolic dysfunction. It is important to monitor daily weights, fluid, and salt intake. Heart failure requires you to do this, and that is accurate. Left-sided heart failure can lead to right-sided heart failure. That's also correct. And this heart failure can cause peripheral edema from venous congestion. That would be incorrect because that would be something that would occur in right-sided heart failure. Very good. Okay. So let's go to the next one. Oh, the questions went away after the first one. Okay, here's the question. You're not seeing it?
When the questions came up, all of the questions came up, like, so it was like 1 through 13. So in order to answer it, I answered the first one and pressed submit, and then it disappeared.
Oh, okay. So I'm going to go back and relaunch it. Okay.
Okay, thank you.
Sure. I'm going to relaunch. All right. So answer number 2. Sorry. Are you able to answer now?
Yes, I see it. Thank
Okay.
you.
Sure. Thank you. Oh, you're all very smart. Okay, so the correct answer is A, B, and C. All right, so distinction is based on ventricular ejection fraction. That is correct, right? When we separate systolic or diastolic function, we base it on the ventricular ejection fraction. We know that in systolic dysfunction, there's going to be a decrease in ejection fraction. In diastolic dysfunction, it's going to be a normal or even increased ejection fraction. So letter A is incorrect. In systolic dysfunction, the ejection fraction is decreased. I said that. And letter C, in systolic dysfunction, the preload increases because of the fact that you're not contracting well, you're going to retain a lot of blood. So A, B, and C are going to be correct. And of course, letter D, in diastolic dysfunction, ejection fraction is normal because contractility is not affected. And preload remains the same or decreases as the preload or the ventricular filling is impeded. So that is the correct answer. Okay, let's go to number 3. Are you able to answer number 3? Or do I need to relaunch? Relaunch. Okay. All right, here's number 3. Okay, so the correct answer here is that left-sided heart failure are going to be caused primarily by acute myocardial infarction and hypertension. All right. Chronic pulmonary disease is going to be a major cause of right-sided heart failure, right? Not left-sided heart failure. Okay? All right, let's go to the next question, and I'm going to end the poll and relaunch again. So we're going to number 4. Okay, so let's see. The question was, the patient has left-sided systolic dysfunction heart failure. Which are expected findings? All right. So letter A, echocardiogram shows an ejection fraction of 38% is correct. This is going to be one issue as far as this is concerned because of the lack of contractile force. Now, letter B, heart catheterization shows an ejection fraction of 65%. This might be so in diastolic dysfunction, but not in systolic. A patient has frequent nocturnal paroxysmal dyspnea. This is going to be correct, and I will explain that in a little bit. But letter D is incorrect. The reason why letter D is incorrect is because of the fact that this is more characteristic of right-sided dysfunction or right-sided heart failure. Okay, so let me explain the reason why patients with heart failure oftentimes are going to have paroxysmal nocturnal dyspnea. All right, so let's say that this is going to, first of all, whenever you have heart failure, right-sided heart failure, your veins, which were something like this before, now becomes dilated, right? Because of the volume that is overwhelming the venous system. Now, when you have a narrow veins or sort of not dilated veins, are the walls thicker or thinner? When you have a normal vein, are the walls thick or thin? They're usually thick. And the purpose for it being thick is they trap substances inside. They don't allow some substances to go out. So they're semi-permeable. They allow some substances to come out of it, but they do not allow some, particularly proteins or albumin, to go out. Now, when you dilate the veins, such as what happens in right-sided heart failure, you lose your semi-permeability. And so what happens is that proteins such as albumin is going to escape. So albumin always attracts fluids. And so when albumin goes out of the vascular bed, particularly in the veins, there's going to be fluid that's going to be attracted to them. This causes the peripheral edema that you will notice in patients. So I hope that you understand that first before we go to the next concept. The next concept is that when patients sleep at night, there's going to be lesser demands for cardiac output. And therefore, what happens is there's a mild resolution of the heart failure, and the albumin now goes back over here and the fluid also goes back over here. When you have a lot of fluid in the veins and you add more fluid, what is going to happen? This is going to increase your ascites, and it's also going to increase the possibility of congesting the heart, the lungs, I'm sorry. And therefore, a lot of patients usually are going to develop shortness of breath. So this is something that you have to remember. For those of you who work in the emergency room or will be working in the emergency room, most of our pulmonary edema in patients that have heart failure usually come in the early morning hours. And that is because of this physiologic explanation that when they rest, what is going to happen is there's going to be resorption or reabsorption of fluid that was trapped in the interstitial spaces. And therefore, the resorption of fluid is going to overwhelm the venous system, and therefore it will increase the ascites and therefore interrupt with the breathing pattern of the patient. It could also occur in as a result of this increase in volume, that it will also congest the lungs as well. And that's the reason why paroxysmal nocturnal dyspnea is going to be a symptom. So the word paroxysmal means to say that it is all of a sudden. Nocturnal means to say that it is night. And then, of course, you all know what dyspnea is. So difficulty of breathing, particularly during the night. All right, so let's go to another question. Okay, could you do number 4? Didn't we do already this question? Yes, okay, let's go to number 5. You already did that too? True. Okay. So the answer here is true. I'm sorry about this confusion right over here. It's my mistake. Okay. So let's move forward and talk about what are the risk factors for the development of heart failure. Well, before we go to the risk factors, let's talk about the etiology. It is interesting that heart failure can affect both men and women. However, the mortality is higher among women. And there are also racial differences. At all ages, death rates are higher in African Americans than in non-Hispanics and whites. And heart failure, therefore, is a disease that is primarily a problem of older adults. So the older you are, particularly if you're older than 65, the more incidence of heart failure there's going to be. And it is actually the most leading cause of hospitalization in individuals that are 65 and over. So the risk factors for the development of heart failure are going to be similar to those risk factors associated with coronary artery disease, which we talked about yesterday. So that would include your hypertension, your diabetes, your obesity, history of blood clots and stroke, as well as viral and family history and toxic medications. Now, some of you might be thinking, what does virus have to do with heart failure? Well, the problem is the virus could cause an inflammation of the myocardium, and that is called myocarditis, and therefore could either result in systolic or diastolic heart failure. So let's examine carefully the causes of heart failure as far as these are concerned. And coronary artery disease, ischemia, both could result in cellular death of the muscles. And so when you have a muscle, supposing this is your, this is your ventricles, but you killed some of these muscles, you therefore are going to lose contractile force because you have lesser muscle mass. Now, cardiomyopathy is an enlargement of the heart. And again, enlargement of the heart could be concentric or eccentric, and therefore could cause heart failure. And systemic hypertension is a very common cause of left-sided heart failure. And the reason for that is if this is the left ventricle and it is pumping against an increase in afterload, what's going to happen is this is going to compensate by enlarging. So the left ventricle eventually enlarges, and therefore this is the most common cause of left-sided heart failure. Pulmonary hypertension, on the other hand, is the most common cause of right-sided heart failure. So again, if you look back at my illustration, if that's the right side of the heart, and this is the lungs, and this is the left side of the heart, if you have disease of the lungs, such as what happens when you have pulmonary hypertension. Pulmonary hypertension is when your blood vessels in your pulmonary vasculature is going to be less, or they're constricted as a result of damage. You're going to develop pulmonary hypertension. And pulmonary hypertension will eventually lead, therefore, in congestion of the right side. So pulmonary hypertension plus right ventricular hypertrophy plus right atrial hypertrophy is what is known as cor pulmonale. Okay, so that's pulmonary hypertension. And then lastly, valvular heart disease. How do valvular disease contribute to the development of heart failure? So let's go to the right side of the heart. And of course, we have over here on the right side of the heart, we have the tricuspid valve. But let's say that one of these leaflets or two of these leaflets are incompetent. In other words, they don't close well, rather they fall down, and falling down is what is known as prolapse. That means to say that when blood comes in here and then goes in here, because these are open or incompetent, the blood goes back and forth. This is what is known as regurgitation. So when you have long-standing regurgitation as a result of tricuspid prolapse or tricuspid insufficiency, this is going to enlarge. And therefore, tricuspid insufficiency can cause, therefore, right-sided heart failure. The other valve on the right side of the heart is going to be the valve that is the pulmonic valve right here. that connects the right ventricle to the pulmonary artery. Let's say that this valve does not open wide enough. Now, when you have a very narrow opening, the condition is what is known as stenosis. And because it occurs in the pulmonary valve, we call this pulmonic stenosis. So what would happen in pulmonic stenosis? The opening of the valve is so narrow. So where would the congestion occur when we have pulmonic stenosis? Where would the congestion occur if you have pulmonic stenosis? No, it would be on the right side or the right ventricle and the right atrium. Because you remember, the blood cannot go in very readily into the pulmonary artery. Okay, so therefore, this is going to result in right ventricular hypertrophy as well as right atrial hypertrophy. Okay. So valvular disease on the left side could also do the same thing. So the valve that separates the left atrium to the left ventricle is called the mitral valve. So again, if this is insufficient or there's going to be prolapse of the mitral valve, it will likewise cause regurgitation. And regurgitation eventually would lead to enlargement of the left atrium as well as the left ventricle. So again, it could cause right-sided heart failure. Now, the aortic valve. So supposing now that the aortic valve again is going to be stenosed. So we have aortic stenosis. What would happen to the left ventricle when you have aortic stenosis? What happens to the left ventricle when we have aortic stenosis? Enlarge, very good. It will enlarge because the blood is having difficulty in going out. And therefore, chronic enlargement of the left ventricle, again, can precipitate or can cause, therefore, your left-sided heart failure. Okay, so let's take a look at this question. And I'm just going to ask you to answer on the chat box. Which of the following patients are most at risk for developing heart failure? Select all that apply. All right, please indicate your responses on the chat box. Okay, so let's take a look at this. It says, which of the following patients are most at risk for developing heart failure? And so somebody who has had MI, and also alcohol abuse is most likely to develop one. So this is very good. And again, 69-year-old male. So that means to say that he's also at risk. The other one, female with history of asthma and hypothyroidism. Well, asthma does not cause the destruction of blood vessels in the lungs and therefore is not going to affect or increase the risk for heart failure. A patient with endocarditis and also mitral stenosis is likely going to have heart failure. Faulty heart valves, as well as viral infection of the heart, could increase the possibility of heart failure. Lung cancer does not have anything to do with heart failure, but this one, uncontrolled hypertension, is going to increase the risk of left-sided heart failure. So A, C, and E are going to be the correct responses. I see a lot of you got that correctly. That's good. Okay, so let's go to the next one. Which conditions are often associated with diastolic failure? Select all that apply. Again, respond to the chat box. Okay, so let's take a look at letter A. It says constrictive pericarditis. All right, so what is this condition? So if this were the heart is enveloped by a pericardium. And if the pericardium is going to be unavailable to expand, so it constricts or pushes the heart, it certainly could result in diastolic heart failure because the heart will not be able to fill. So this constrictive pericarditis is going to be correct. All right. Myocardial hypertrophy, we all know that the increase in the thickness of the ventricles could reduce the chamber size, and therefore myocardial hypertrophy could also cause diastolic heart failure. And lastly, ischemic heart disease. Ischemic heart disease will eventually delay diastolic relaxation because of the fact that the heart is not getting enough oxygen, and therefore, excuse me, it's going to delay the relaxation of the ventricles. And that is why A, B, and C are going to be associated with diastolic heart failure. Volume overload is going to be most likely result into systolic failure as well as valvular stenosis. As we said that in valvular stenosis, what's going to happen to the heart? It's going to enlarge. And when we enlarge it, then that means to say that we're going to have a weaker contraction. So let's go now to the manifestations of right-sided heart failure and left-sided heart failure. In left-sided heart failure, you're going to have all things that are associated with the respiratory system. Dyspnea or shortness of breath, as well as cough, and also crackles are going to be manifest, as well as low oxygen saturation. And in right-sided heart failure, I want you to know that in addition to the things that we had talked about as well as far as hepatomegaly, venous engorgement, it could cause GI symptoms. And the GI symptoms, because of the congestion, can result in different things. One of them is going to be bloating, the other one is going to be ascites, but more importantly, there's going to be, of course, loss of appetite. So those are the most classic signs and symptoms of left-sided and right-sided heart failure. All right, which questions will the nurse ask to confirm heart failure? Select all that apply. Could you please answer this question again? Okay, let's discuss. Which questions will the nurse ask to confirm heart failure? Do you easily get tired? This is a correct response. And the reason is that heart failure actually is manifested by activity intolerance. That would be your number one nursing diagnosis is going to be activity intolerance in these patients. They're not going to have activity tolerance because of the decrease in the cardiac output. Do you have swelling in your ankles? This would be a question directed particularly if we suspected right-sided heart failure. Are you eating more than usual? Well, this sounds like it is going to be contrary to the signs and symptoms of right-sided heart failure, which includes a loss of appetite. So that would not be correct. Are you feeling depressed? Now, remember that heart failure is very common in the elderly. And as they decline in their activities, usually they are going to develop depression. And so this is not uncommon. So letter D is correct. And then, of course, letter E, as I have explained, the resorption of trapped fluid in the interstitial spaces, letter E is correct because nocturnal polyuria, nocturia, I should say, is going to be a very common finding in these patients. Okay, so what are some of the diagnostic measures or findings that we're going to rely on? Well, the most common ones are the ones on the left side. The ECG is going to be very important because it could tell us whether or not there is enlargement of the heart. So that's the important thing. And then it could also tell us whether or not there is arrhythmias, which could even be a factor in increasing the symptoms of heart failure. Chest X-ray is also going to be very important because, again, enlarged cardiac shadow is very, very telling that there is heart failure. And then, of course, we could also see whether or not there are going to be fluid that is going to be trapped in the interstitial spaces in the lungs. Heart scan, sonograms are going to be very useful as well as exercise, stress tests, as well as PET and cardiac catheterization. Obviously, these other things right over here that are listed are contributory to the diagnosis or the complications that might accompany a heart failure. Now, I wanted to go to another diagnostic finding that we rely on in patients who have heart failure, and that is your natriuretic peptides. So what are these? Well, these are hormones that are released by the heart. It is released in response to distension of either the atria and or also the ventricles. So if it's in the atria, it's called ANP. If it is in the ventricles, it's called BNP or B-type natriuretic peptide. So again, this signals the body to compensate for this decrease in cardiac output. And so therefore, whenever we have an elevation of your BNP, which is much more better as far as diagnosing heart failure is concerned, then that would be much better. So this is the hallmark or the golden standard for the diagnosis of heart failure. And the normal BNP is less than 100. This is normal. However, if the BNP is going to be 100 to 300, and I think it's picograms per milliliter is the value, this is now an indication that there is heart failure. Okay, so a BNP of 100 to 300 is going to be diagnostic of heart failure. All right, so ANP could also be elevated. The normal ANP is 20, but we don't rely on ANP as much as we rely on BNP. So I want you to remember that BNP, the concentration or the increase in BNP, is the biomarker that tells us that there's excessive pressure in the heart due to heart failure. Okay, which of the following tests or procedures are not used to diagnose heart failure? Not use. Okay, please answer in the chat box. Okay, very good. Holter monitoring is useful for the identification of arrhythmias, but it doesn't tell us anything about cardiac function that would manifest the presence or absence of heart failure. Okay, so it's not used to diagnose heart failure. All right, whenever we have heart failure, we have talked about either compensated or uncompensated, left-sided or right-sided, systolic or diastolic. It's a lot of different terms. But the American College of Cardiology and the American Heart Association has developed a staging system of heart failure. And I just wanted to mention this because it might come up. But anyway, stage A to stage D, this is going to be easy to remember. Stage A means to say that there are no symptoms of heart failure. But when we go to stage C and D, we now have signs and symptoms of heart failure. There's another classification system, and that's the New York Heart Association classification system. They similarly are going to stage heart failure, but they use numerical staging. So it's 1, 2, 3, and 4. And again, in stage 1, there are no symptoms. In stage 4, there are severe symptoms. So again, this is easy to remember, okay? And lastly, let's talk about the medical management of these patients. How do we treat patients with heart failure as far as medications are concerned? Well, the medications that are used are ACE inhibitors. And the reason why ACE inhibitors have been found to be useful is because they slow the progression of heart failure and they improve exercise tolerance by producing vasodilation and decreasing afterload. So the major effect over here is to decrease afterload. And these are your drugs that ends with the suffix pril, right? So do you remember examples of ACE inhibitors? Well, anything that ends with a pril, like lisinopril, captopril, and other things that are going to end with pril. These are ACE inhibitors. Your angiotensin receptor blockers act the same way as your ACE inhibitors, and they're the medications that end with the suffix sartan. So if you recognize sartan, think about that it is an angiotensin receptor blocker. And examples of that would be your losartan, candesartan, valsartan. So anything that ends with a sartan. Beta blockers are useful in the sense that they decrease the demand for cardiac oxygen. And they're the ones that are going to end in the suffix olol, your carvedilol, labetalol, propranolol, and metoprolol. All those are going to be very helpful. They are going to be given in patients in order to reduce the demand for cardiac oxygen. Digoxin. Digoxin is going to be very useful, but this is going to be useful in one heart failure. So would it be useful in systolic heart failure, or would it be useful in diastolic heart failure? And why? Which one are we going to use digoxin in? Yes. Why systolic? Remember that in systolic heart failure, your ejection fraction is decreased. And therefore, the action of digitalis is going to increase the force of cardiac contraction. Now, in diastolic heart failure, you don't have a problem with cardiac contraction, and therefore you're not going to need digoxin as much. And then, of course, you have your ivabradine and nisiretide, as well as your Entresto. These are medications that are going to be a recombinant natriuretic peptide. And your Entresto is a combination of your angiotensin receptor blockers, and therefore they reduce strain in the heart. So these are new medications, your Natricor, as well as your sacubitril combination with valsartan, which is Entresto. Now, other than medications, part of the problem with the fact that you enlarge the heart, if you enlarge the heart, what's going to happen is this. So let's say that this is the right atrium and the right ventricle, and then this is the left ventricle. It now is hypertrophied. Whenever you have this, you're going to have arrhythmias because this is contracting and this is still not contracting because it's too big. So there is what is called desynchrony, and it results in a decrease in cardiac output. So what we do in this instance is to insert a pacemaker type device in order to resynchronize them. So that's cardiac resynchronization. That means to say that we're going to insert a pacemaker in the heart so that when this contracts, the right side, this left side also contracts. So that's cardiac resynchronization therapy. And an implantable cardioverter defibrillator is indicated primarily for the prevention of sudden cardiac death in patients who have heart failure, particularly those who have an ejection fraction of less than 35%, because at any moment they're they're going to die with a arrhythmia. And that is the reason why an ICD, or an implantable cardioverter defibrillator, is going to be inserted. Okay? And of course, lastly, heart transplantation. Okay, let's answer this question. A patient complains of dyspnea, cough, and difficulty of breathing with crackles, respiratory rate 25, SaO2 90%, which confirms the heart failure. And a lot of you answered the correct answer, BNP of 820. Remember that the normal BNP is going to be 100 or less, but 100 to 300 indicates the presence of heart failure. All right, so which types of medications are usually prescribed to manage heart failure? Okay, so do we give diuretics? Yes. Do we give digitalis? Yes, particularly to systolic heart failure. Non-steroidals do not have any bearing at all to heart failure. Beta-adrenergic blockers and ACE inhibitors are going to be used. So it's A, B, D, and E. Very good. Let's talk about further nursing implications as far as these patients are concerned. It is obvious that you need to monitor intake and output. And the best way to monitor intake and output is not only to measure urine output and intake, but also to weigh them daily. So when we weigh them at the same time on the same scale, usually in the morning after the patient urinates. So the rule of thumb is anytime there is a weight gain of 2 to 3 pounds, which is 0.9 to 1.4 kilograms, in a day, or a 5-pound gain in a week, this indicates trouble. This means to say that the patient is retaining a lot of fluids. So this is an indication that you need to act, to intervene, to increase the interventions that you're doing. As far as physical examination is concerned, I also want to emphasize that the jugular neck vein distension is going to be evident in patients with right-sided heart failure. And lung sounds and heart sounds are going to be important in lung sounds, particularly in left-side heart failure, and heart sounds for both right and left-sided heart failure. And then, of course, always assess for fluid overload. That ends our discussion on heart failure. And now the next part of this presentation is our case study. And I encourage you to go back to the case study. And I think I had indicated in the in the link how to go to the case study. But this is the case study. I'm going to put it on the chat box so that you will be able to access it. And for the video recording from yesterday, for those of you who want to review that, this is also the link to that on YouTube. Okay. All right, so let's go to this case study. We have a 68-year-old male presenting for a routine clinic appointment, reports tiring easily when out shopping for walks, has been staying home reading and watching television, reports difficulty sleeping, awakens with shortness of breath in the middle of the night, reports 8-pound weight gain over the past 2 weeks since the last appointment, states normal appetite, denies chest pain and back pain, states he is anxious about his condition, no known allergies, current medications, enalapril, 20 milligrams twice a day, hydrochlorothiazide, 25 milligrams twice a day, PO, digoxin 0.125 once a day, assessment alert and oriented, appears slightly anxious, heart rate regular at 102, and 4+ beating pedal and pretibial edema, respiratory rate unlabored, crackles in the bases bilaterally, abdomen soft, non-tender, bowel sounds active, skin warm and dry and intact, frequent urination, small amounts of clear yellow urine. The vital signs are displayed right over here. And now we're asked, which four findings are concerning? So again, this is going to test you to determine if you could recognize the symptoms that you have to act on. All right. So letter A, will you die as a result of being anxious? So again, remember to go back to your Maslow's hierarchy of needs. Anxiety is not going to be a priority at this time. But let's take a look at letter B, 4 plus pitting and pitting pedal edema and pretibial edema. Is this concerning? Is this? Yes, it is concerning. This is not a good finding at all. So I'm going to choose that. I agree with you. How about crackles in the lungs, in bilateral lung bases? Is this serious? Could you die as a result of it? And the answer to that is yes, because it could progress to pulmonary edema and therefore could kill you. Okay, so crackles in the bilateral lung bases are going to be important. Frequent urination, will you die from frequent urination as well as a lack of appetite? No. Okay. How about awakening at night with shortness of breath? What is this indicating to us? The presence of pulmonary edema. So we're going to choose this one. And how about the weight gain? You remember the weight gain? Reports 8 pounds weight gain. Is this dangerous? Yes. Okay. So, and the heart rate? The heart rate is only 102. You're not going to die as a result of a pulse rate of 102. Okay? So that would be how I would answer this question. All right. So let's now go to the next one. What two problems is the client at most risk for? All right. So there's a lot of choices over here. So give me one that would be the most indication of a worsening of heart failure. E, very good, Perlier. Very good. I would choose your fluid volume overload, okay? Because this, the fact that the patient is demonstrating all the signs of heart failure, this is going to indicate that the fluid volume overload is going to be a complication of this particular situation. What other complications might occur as a result of this? All right. So the patient is taking hydrochlorothiazide twice a day. What is hydrochlorothiazide? It's a diuretic, right? And so therefore, the patient might become hypokalemic if he's not including enough potassium in his diet. So therefore, he's going to be at risk for electrolyte disturbances. So electrolyte imbalance is going to be one of them. All right. Just because you're in heart failure, would you develop anemia? And the answer to that is no. Are you going to develop dehydration as a result of it? And the answer to that is no. Heart attack, maybe. How about diabetes mellitus? No, there's no connection at all. Hyperkalemia, no, because he is on a diuretic. And then thrombophlebitis, there's no indication at all to suggest that he will develop thrombophlebitis. Okay, so now we're given the laboratory report, and as you could see, the results include the reference range. So the new Nclex will tell you what the normal values are, so you don't need to memorize them. But let's say the lab cholesterol is 248 and normal is 200, so we say that this is elevated. BUN is okay. Creatinine is also mildly elevated, so it's very mildly elevated. The hematocrit is 34.6, and as you could see in males, it's supposed to be 42. So this is decreased, and I'll explain that in a little bit. Your hemoglobin is normal, your potassium is decreased, and your sodium is normal, and your chloride is also okay. All right, it's mildly depressed or decreased, I should say. Which abnormal finding should the nurse address first? All right, so you have a potassium of 2.8. Can a potassium of 2.8 kill you? Yes, you will develop ventricular tachycardia. So potassium obviously is going to be our number one problem. Cholesterol is something that you cannot correct right away. And the hematocrit is low on this patient. And the reason is of the dilutional decrease in hematocrit is what's happening. You have a lot of fluid volume collected in your body, and obviously, therefore, it's going to decrease the concentration of your blood, and thus your hematocrit will be decreased. Okay? And so the correct answer here is letter A. So we continue with this, and let's see at there's nothing new here. What should the nurse include in the teaching plan for this client? Select all that apply. Letter A, would you weigh yourself every day at the same time and in the same clothes? Yes or no? A, yes or no? Yes. Okay, very good. Should the patient increase their fluid intake? Letter B, no. And letter C, limit sodium in the diet to no more than 2 grams per day. True, yes or no? Yes, very good, because we want to decrease fluid retention. Immediately report 1 pound weight gain in 1 day or 3 pounds in 1 week. No, okay. So do you remember that the 1 day weight gain or 3 pounds in a week is going to be normal, but anytime it's going to be 5 pounds in a week, that is going to be very significant. And how about limit exercise and physical activity? Just because somebody has heart failure, do you want to limit their physical activity? And the answer to that is no. You always encourage the patient to be active so that to their tolerance. So this letter E is not. Take prescribed medication every day, even if feeling better. Yes or no? Yes. And eat foods that are high in potassium. You remember the patient was taking hydrochlorothiazide, and therefore letter G is going to be correct. Okay, so let's now go to the next one. And this is the new finding. At 10:30, the order is to discontinue digoxin and begin sacubitril valsartan, 49/51 milligrams PO daily, along with nutrition dietitian consult. Begin low sodium diet and fluid restriction of 1,500 per 24 hours. Instructed to weigh himself daily and record, and return to clinic in 3 weeks for follow-up. Okay, so that's the only thing that changed so far. And now we're going to go to this question. Which of the following actions should the nurse take in response to the change in the medical records? All right. Would you question the new medication order? So let's take a look at the new medication order. Or, order to discontinue digoxin and begin valsartan along with nutrition consult. All right. So this is hard, and that's why I want you to take it in the link that I had told you. This is actually a correct response, and the reason for this is that the new medications for sacubitril and valsartan should be questioned because the patient is already taking an ACE inhibitor. So that's the reason why we need to question that medication order. But how about educate the client about stopping digoxin? Yes or no? Yes. Okay. So we want to educate the client about stopping the digoxin. That means to say that we're going to advise the patient to make sure that they continue to monitor their pulse, for example. How about instructing the client to start the new medication today? Well, he already had the medications because this was at 10:30 and the medications were given at 10. So this is not going to be good. Tell the client to take an additional dose of diuretic today. Well, the nurse never tells additional doses of diuretic therapy. Only the physician will do that. And how about request the provider to order a potassium supplement? Yes, okay. So why is that important? Well, it is important because now the patient is going to be on was on hydrochlorothiazide, and therefore it's imperative that we either increase potassium in the diet or supplement their potassium. Ask the dietitian to meet with the client. Obviously, this is going to be yes, and determine if the client owns a weighing scale. The patient is not going to be able to weigh himself if he is not going to have a weighing scale. All right. So going back to sacubitril and lisinopril, these are contraindicated to be used together. It is not recommended because it might cause an allergic response or angioedema. And that is the reason why it is never used together. Okay, sacubitril could not be used with an ACE inhibitor like lisinopril. All right, so on day 14, this is the new one. At 8:30, the client now called the clinic to report nagging cough. Let me just enlarge this. Pink tinged sputum, and difficulty catching his breath. This is not good. He states he's sleeping in a recliner because he can't breathe when he's laying down in the bed. Notes that the wife checked pulse and it's 90. Reports lack of appetite, thirst, and getting up twice per night to urinate. States he is worried about his health. Advised the client that worsening symptoms need immediate attention. Spoke with the client's wife, who agreed to take him to the emergency room. And I think the laboratory findings are going to be the same. The only thing that has changed are the vital signs. Okay, so let's go now to on day 14, the nurse calls the client to follow up. For each finding, click to specify if the finding indicates that the client's status has improved, worsened, or is unchanged from his condition at the clinic 2 weeks ago. Is sleeping in the recliner improved, worsened, or unchanged? It's only Perlier that answered. How about the others? Okay, very good. So I would say that this has worsened. How about the nagging cough? Is this improvement, worsening, or unchanged? Worsened, okay. And the pink tinge sputum, would that be improved, worsened, or unchanged? That is worsened. Difficulty in catching the breath, it's worsened. The pulse was 102 right now, and before it was 102. Okay, so 102 and 102. So that means to say that it is unchanged. And how about the lack of appetite? Lack of appetite? It's worsening, right? Okay, so that's worsening. Getting up at night to urinate? See, I think that he was he had improved and now he's going to urinate more frequently at night. So this is worsened. And of course, the thirst, he has been thirsty before. I'm sorry about that. And therefore, that is unchanged. Okay. So I encourage you to go to the website, to the link that I pointed out to you so that you could look at them. I could not display it as well over here as it is in the link that I had shown you. So that is the presentation on heart failure. And I'd like for you to encourage you to go back to the recordings, and the recordings could be accessed on my YouTube channel. And you could also subscribe if you wish. And these recordings are all on Nclex. There is a section on Nclex, there's a section on ECGs. There's so many topics over there, but the Nclex review is what you would like to access. So I want to take this opportunity to thank all of you, and I'm glad that we have a lot of participants today. I look forward to having you again. Today is Thursday, right? uh, so I hope to see you again on Tuesday, same time at 4 p.m. to 6 p.m. So thank you once again, and I hope to see you on Tuesday. Thank you.